Good day, my dear postgraduate students. The topic that I am going to cover for you people is twofold. A technical topic with its interpretation. The first part shall be the technical part. Liver biopsy, part 1 for postgraduates. I always used to say the sayings of my dermatology HOD, Dr. Augustine Pope. Think of the subheadings. The subheadings will take you to the answer. And for any of such ones, I would like you people to kindly compile your own sets of subheadings. Even this class, do not panic and scramble. Be slow and deliberate. Speed will come to you automatically. There will be a general approach, indications, clinical and laboratory findings, instruments, microscopy, special stains, IHC, contraindications, the clinical background as such, and the complications. Now, what will be important will be the request form, in which we have got umpteen number of details because the liver itself is huge and it has to be superimposed on the other findings. This biopsy was introduced in the year 1883 by Paul Ehrlich and 1958 by Mengele was the further development. And there are certain other things which we shall be seeing in due course. It is not a simple procedure, and you will be finding that there is a set of specialists such as the hepatologist, the surgeon, gastroenterologist, radiologist, and pathologist, whose contribution will be of immense importance in making a diagnosis. Coming to the histology, always I would like you people to see this picture on my right. Definitely you are very familiar with the central vein, the radiating cords of the hepatocytes, the intervening sinusoidal spaces, and towards the edge of the lobule, I am able to see the portal triad. Functionally, however, the periportal region is called as 1, the perivenular region as 3, and the intervening part of the lobule as 2. So this will be important. At the other side, this is something, a basic recollection of the reticulin stain. I find that the liver is being supported by a delicate reticulin framework. And intervening the pale pink area is, of course, the parenchyma. This we shall be having in mind. Central vein, radiating cords of hepatocytes, and the portal triad, intervening sinusoidal spaces. And of course, the adjoining lobules do not get segregated by means of any line. In fact, there is a very highly invisible limiting plate that is seen, which must not be drawn. Now, what are the indications of the biopsy? First and foremost shall be a diagnosis. There are lots of diseases which can be diagnosed. In fact, my professor of medicine used to say, the single most reliable investigation in liver disorder shall be a needle biopsy. It can be for differentiating the various autoimmune disorders, NASH, Wilson's disease, which can be a mimic for many a condition, hepatocellular carcinoma and cholangiocarcinoma, hepatitis, and metastasis. These are certain things which we can generally diagnose. On the other hand, we have got various processes such as an inflammation, a chronic hepatitis. Different etiologies are there. We will not be delving into it now. Cirrhosis, again of varying etiology. Storage disorders. The changes in a post-liver transplant. Enzyme disorders. Cholestasis. Space-occupying lesion. Primary or secondary whatsoever. So this can be another set. In one, we almost know the diagnosis, whereas in another, it is a process that is ongoing, for which we will have to find a diagnosis. Also, you find that there has to be the prognosis. Non-alcoholic steatohepatitis, that is one. Hemochromatosis, cirrhosis, some of which might lead to hepatocellular carcinoma. And the treatment, what are the immunomodulators for the local tumor ablation? And incidentally, this is the superb source of reference with which or to which we shall lean on. In fact, Dr. Michael Torbenson has been very humble to recall the first two editions and the improvement that he has struggled to make. In fact, it is a marvelous presentation to which I would like to lead you people. And these are his words. In my own training in liver pathology, which I suppose never really ends, I have greatly benefited by the excellence of my teachers and colleagues. That is what pathology is. Coming to the instruments. Whenever there is a question like the biopsy, you people should always have this subheading. It is a 16 to 18 gauge long needle. You find that it is relatively firm when compared with the lumbar puncture needle, but then less so with the bone marrow needle. There are two entities. One can be an aspiration. So the needle is poked in and then you aspirate the material, you find that the contents go into the needle. There can be a suction syringe which increases the negative pressure. The third one or the second one can be a cutting needle, in which there will be an external covering and then there will be an internal one. So which is used for cutting, and then we get a bit of the tissue as a biopsy. Normally, a representative biopsy should be having about 10 portal tracts. It should be 3 centimeters long or at least 2 centimeters and about 1.5 to 2 millimeters in width. Fragmented biopsy is generally inadequate, but it should not be lost because we can see some pathological process in it. So for the adequacy, we need the size of the lesion and then the lesion itself. Sometimes if it happens to be a tumor, these conditions can be bypassed. You are directly staring at the disease. You should be able to stage and grade the number of portal tracts and the length of it we have already mentioned. As I told you, there can be a suction needle. It can be a Shiba, Mengeni or a Jamshidi needle. A cutting needle can be a Wim-Silverman or a true cut needle. This is what I had been saying. This is a stillet that we people are seeing, and this is a cutting needle that is there. It has got a sharp edge which can pass through the tissue. Usually a nick is made in the skin and the subcutaneous tissue, and the needle directly passes into the hepatic parenchyma. Care should be taken to avoid injury to the blood vessels and the intercostal nerves. What happens here is this forking type of a stillet will be able to catch the biopsied specimen and when it is being withdrawn, it comes along with it. Great deal of sterile precautions will have to be taken. It is almost like a mini OT procedure. It can be done as an outpatient, but then it is better that the patient is admitted for an inpatient watch for a period of few hours so that he recollects or recovers without any problem. And before any of this biopsies, if he is on any medication, those should be stopped 5 days prior to the biopsy. The blood count should be normal. The platelet should not be less than 60,000 per cubic millimeter. The coagulation profile should be near normal. Maybe on a light snack, and then if the patient is too very anxious, there can be a little bit of sedation. Anesthesia is recommended for an over-anxious patient. And as usual, an informed consent is essential. Now, when you people examine the liver biopsy, this is the hepatic lobule. A beautiful picture of it, maybe this is good enough. I find that at the alternate angles, I will be able to find the portal triad. Portal triad means there can be the hepatic artery, the portal vein, and the lymphatics. It is roughly hexagonal in outline, but then there is no obvious limiting break that can be seen. And these are the chords of the hepatocytes. Always we should be having this in mind. The central vein is of course central. And when we do a report, it has to be from the central vein to the portal area. Comment on the veins, the hepatocytes, the biliary canaliculi, the stellate cells, and the deposits that could be found in the space of disease. Any inflammation, you will have to specify whether it is periportal, perivenular, or is it scattered. Areas of necrosis. Cholestasis, of course, is important. It can be minute in hepatic disorders and it can be marked plugs in a case of biliary disorder. Proliferation of the ductules. Again, it can be in many a condition, including biliary cirrhosis. Fibrosis. These are things. Courtesy Southern Illinois University for this wonderful picture. Now, what are the things that we people will have to look into? Let us recollect that there can be a delicate core needle biopsy. There can be a larger wedge biopsy. A core needle biopsy, it has got its own limitations. Sometimes it can break and you will not be able to get multiple deeper sections, which can be compensated by means of a wedge biopsy. Plugged biopsy is almost similar to the core biopsy. Only thing it has got the plugging with a gel foam, which I shall be explaining. You'll have to go through the capsule and then this should be the thickness of the bits. Multiple slides will be needed and step sections. It need not be serial sections, but step sections. Some amount of tissue, of course, will have to be preserved. As a procedure, a physical localization of the liver is essential. There has to be a palpation and a percussion of dullness, at which site the aspiration is done to avoid a pneumothorax. Sometimes it can be image guided and there can be a real-time image in the form of ultrasound or CT scan. This is the local anesthetic that is being used. And rarely there are other modes which I shall be explaining, such as the transjugular or transfemoral. These are used in some patients who are otherwise compromised. For example, chronic kidney disease or post-transplant. The precaution shall be, you will have to avoid aspirin, any of the blood thinners, alternate medicine other than allopathy also should be ruled out, diabetes on treatment and non-steroidal anti-inflammatory drugs. So this we shall be having in mind, delicate core needle, large wedge and the plug biopsy. This is again a beautiful set of pictures over here, courtesy ResearchGate. Look at the various types of needles which are possible. The sharp cutting edge should be borne in mind. Sometimes it can have the function of a drill so that the biopsy goes directly into the needle. These are the various ones, and I am not an expert at it. You can discuss with your other counterparts. And these are the various names which have been given to it. Kindly follow. Plugged liver biopsy, it is a modification of the percutaneous biopsy. The patients with impaired coagulation, they can be having this plugged liver biopsy. A transjugular route, when it is not available, then you will have to do only the percutaneous route, and then for that there can be a plugged liver biopsy. It is done by the usual conventional method. Only thing, look at this picture over here. After the aspiration or the biopsy, gelatin is injected so as to seal the defect. And courtesy, this is the reference, you people can go to it. The picture is from the reference. Laparoscopic biopsy. Sometimes it can be done for staging. Ascites of unknown origin, peritonitis, abdominal mass, as an ERCP, and unexplained cases of hepatosplenomegaly. Look at the fork that is safely holding the tissue. Transjugular indications. Sometimes through the jugular vein, we go in for this. This can be done in a case of coagulopathy, wherein you find that the INR is greater than, or it should not be greater than 1.5. Thrombocytopenia, where the platelet count is less than 60,000, you will not do it. So when the coagulopathy, when it is more than 1.5, there can be a risk of bleeding. Ascites, obesity, any other fulminant disease. Vascular tumor, obviously you people do it. Pileosis hepatis, again, it is an abnormality wherein there is a vessel without a wall. There is lakes of blood without any endothelium. And in cases of failed percutaneous, you can do a transjugular. See what is being done over here. Through the jugular, through the vena cava, and then it is being gone to the inferior vena cava, and it goes to the liver. The complications in this procedure also can be hemorrhage. There can be a perforation to the capsule, fistula formation with the adjacent tubular structures, hematoma in the neck, cardiac arrhythmias, and pneumothorax. So these are certain complications. Kindly bear them in mind. Thanks to ResearchGate. Post-biopsy will be the patient factors. What kind of the condition the patient is, adequacy of the specimen, whether the portal tracts are adequate and the length of the sample is also adequate. But we should remember, repeat biopsies are not recommended because it is a highly vascular structure. More biopsies, more complications. Thanks to StatPulse, this is again a wonderful source of reference. I would like you people to kindly go to it. What are the zones and the patterns of liver injury? In the first picture, we had seen the different zones of the liver. This is again a diagrammatic view of the same, a beautiful picture as such. The reference is over here, curl K. This is the portal triad, and then this is the central vein, this is the sinusoidal space, and these are the hepatocytes. And this can be the biliary duct as such. I am seeing the green color. Now, what will happen is this, we can call it as zone 1. We have labeled it as portal is zone 1 and central vein is zone 3. So, in the portal region, it is usually useful for the autoimmune disorders or any viral infections. So, it is given in small letters over here, you people can. And the central vein, on the contrary, it can be used for any of the cardiac abnormalities. So, this is primarily for a liver abnormality. and this can be for a cardiac abnormality. Remember your classical nutmeg liver, but shear is etc. Ischemia, toxemia, cardiac failure. The contraindications for a liver biopsy will be uncooperative patients. So obviously anesthesia would be required because it is a mandatory investigation. Risk of bleeding, we have already said. INR when it is more than 1.1 and the platelet count is too low. Vascular tumors, obviously there should be great precautions. Other contraindications we have mentioned. Coagulopathy and bacterial peritonitis. Be careful when we are going to meddle with an abscess, we are going to help in the spread of infection. The complications again in an aspiration or a biopsy can be bleeding, sepsis, pain, refer to the shoulder. Bile peritonitis. Bile is a very powerful enzyme, and when it is going to be spilled, it is going to cause a chemical peritonitis. Pneumothorax, avoid the lungs. Hemorrhage, hemothorax. Dizziness, the vasovagal attack. This can be more common when the jugular root is being tried. So this can be arteriovenous fistula, carcinoid crisis. Release of some of the elements can lead to this. Therefore, you will be finding that skilled operators under precautions and supervision are needed. What are the stains that could be used? There are plethora of stains which you as postgraduate students shall and will remember. HNA is of course one. Mesenteric for the type 1 collagen. Any form of fibrosis, as in the case of cells. Reticulin, it can be a premature delicate stage of it, and whenever there is necrosis, you find that there can be a collapse of the reticulin framework that can again happen in early hepatitis, going in for cirrhosis. Van Giesen, again for the collagen. Serious rate for type 1 and type 3 collagen to demonstrate fibrosis, it is supposed to be better. Pass with diastase, any of the non-glycogen carbohydrate, complex carbohydrate. It can be in the case of alpha-1 antitrypsin deficiency, sometimes in the case of storage. Pearl's Prussian blue for iron hemochromatosis, Orson stain for copper in a case of Wilson's disease, or sometimes you find it can be in hepatitis. Congo red for amyloid, oil red for lipid, and Victoria blue stain for elastin, cholestasis. So this particular table you shall and will memorize. Basically, these will be the pathology underlying it. Inflammation, fibrosis, granuloma, steatosis, storage, autoimmune disorder, and pneumonitis. What are the 6 general responses that are seen in the liver which you would like to diagnose? It can be degenerative disease. It can be accumulation, intracellular, necrosis, apoptosis, Councilman bodies, for example. Inflammation, regeneration, and then a fibrosis. Look at this one. You find that there are bands of fibrosis, and then there is a lobule which is devoid of a central vein. And of course, this is called as effacement of architecture. So fibrosis, mesenteric is shown over here. To demonstrate any of these, you will be needing a liver biopsy. The limitations of a liver biopsy, as I mentioned earlier, all said and done, it is an invasive procedure. It has got its own complications and difficulties. Variability in assessment. According to different pathologies, it can vary. There can be discrepancy in the grading and the staging. Also, the intra-observer as well as the inter-observer variability. When I look at the slide at different times, I can have different opinions. So also will there be a variation in the opinion between various pathologists. Morbidity, of course, can be there. Mortality is very rare. Think of the vasovagal attack or bleeding. Cholestasis courtesy Wikimedia. So when I say cholestasis, it is the stasis of bile. It can be intrahepatic, as in the case of infections, metabolic disorders, duct anomaly, endocrine disorders, drugs, ischemia, sepsis, and so on. Extrahepatic biliary atresia, any form of tumor, cholelithiasis, or any other form of obstruction. If it is very difficult, this is what our classical Robbins itself gives. We can remember this one. Biliary cirrhosis, sclerosing cholangitis, question for us. Hepatocellular disease, alcoholic as well as viral hepatitis. And miscellaneous can be. These are quite rare, but then we should have it in mind. Look at this. There are the hepatocytes in which I am finding faint amount of this bile, which can be seen. Beautiful golden brown. The differential diagnosis, of course, is the hemocyanin pink. Whereas in a biliary obstruction, there can be fibrosis and then bile lakes. The bile lakes are seen over here. Granulomatous hepatitis. I am touching upon one or two conditions, after which I shall be seeing the rest in the second half. Granulome. Look at this one. Classical accumulation of the macrophages. Sometimes it has the appearance of an epithelioid cell, slipper-shaped nucleus, and then there can be even the Langerhans type of giant cells. Coming to the special strain, we already mentioned, but when you think of infections, etc., Gram stain, Crocots, PAS in the case of fungal infections, and obviously Zeal-Nielsen, modified Zeal-Nielsen in the case of tuberculosis. So this particular one is case of drug-induced liver injury, bile duct injury leading to granuloma with giant cells. So all need not be tuberculosis, hence a coordination with the history is needed. These are of course the proliferating ductules which I am seeing. Granulomatous hepatitis, courtesy Anthony Chan. Beautiful set of pictures this doctor has given. This can be in a case of, as I told you, the granuloma can be tuberculosis, sarcoidosis, biliary cirrhosis. Hodgkin sometimes can have granulomata, suppurative fungal. And this is a case of a lipogranuloma. Lot of these adipocytes are there, and when it is going to rupture, there can be this foamy macrophages that are the accumulation leading to a granuloma. Infections, of course, you have got the Coxiella, CMV, giant cell R.A.T.S, and leishmaniasis. Sometimes leishmaniasis can be a slight forest, cytomegalovirus can be a slight forest in the exam. Schistosomiasis. There is a refractile egg that is over here. Walter Stoller, this is the author from which I derived most of the text. It is a refractile egg surrounded by the macrophages. And of course, there is a set of fibrosis and then there are the lymphocytes. Classical to prevent the spread of the infection or the allergic reaction. Radiology plays a very important role. So basically the radiology, they have divided it into three. One is a focal lesion, which can be benign for treatment, and malignant. Benign in one, there is no treatment needed, as in the case of a hemangioma, just observe. Malignant, obviously you'll have to treat, and you'll have to differentiate between hepatocellular and cholangiocarcinoma or metastasis. Diffuse, when there is a widespread inflammation, storage disorders again. Benign based on the tissue again, it can be cholangiocellular or hepatocellular, or sometimes it can be mesenchymal. So what is the origin and what is the lesion that is being produced? This can be the radiological base upon which they arrive at a diagnosis. And be very careful. Today, radiology, earlier it used to be a follow-up of the pathology, but now they have got an excellent dictionary which leads to the diagnosis. We should follow the differential. A smooth appearing cystic lesion, think of hydatidiform. And again in radiology, there can be multinodularity over here. Sometimes it can be having a Cushing border, which is the case of a hepatocellular carcinoma. There are solid areas, cystic areas. Nodularity can be there. Sometimes it can be multifocal. To be continued, and I shall be seeing you in the next class.